Welcome to the Cover 2 Resources podcast series, a podcast series about addiction and addiction education. My name is Amy McNeil. I lost my brother Samuel to a heroin overdose on October 23, 2015. He was 28. As a family, we thought we were prepared to help Sam fight addiction, but we were painfully mistaken. My family founded Cover 2 Resources in memory of Sam. Our mission is to arm others with the knowledge needed to best support a loved one struggling with opioid addiction. The Cover 2 Resources podcast is an ongoing series in which we interview experts in the fight against opioid addiction. It is made possible through donations and sponsorships from concerned individuals or organizations. If you want to help in the fight against opioid addiction, please consider donating or sponsoring the Cover 2 podcast. Go to cover2.org for more information. This podcast is available on iTunes, Google Music, Stitcher, and via RSS feed. Simply search for the full name, Cover 2 Resources, on your platform of choice. Thank you for listening.
Hi, this is Greg McNeil, founder of Cover 2 Resources. While the Trump administration prepares the presidential order to declare the opioid epidemic a national emergency, governors in 6 states have already declared emergencies to deal with opioids. Those states range from Alaska and Arizona in the west to Florida, Virginia, Maryland, and Massachusetts in the east. Here today to talk about the opioid epidemic in his state and what declaring a state of emergency has meant to those struggling with opioid use disorder is Dr. Jay Butler, the Chief Medical Officer and Director of the Division of Public Health at the Alaska Department of Health and Human Services and Chairman of the Alaska Opioid Policy Task Force. So, Doctor, welcome.
Oh, thank you, Greg. It's a pleasure to be here.
So, let's start off by, if we could ask you to share with us the impact of the opioid epidemic in Alaska.
I think Alaska is a great example of the extent of the opioid crisis in North America because it shows that there's no part of our country that hasn't been touched by this crisis. While our rates are not as high as what has been seen in parts of New England and in Appalachia, they're still disturbingly high. And we've seen the increases starting with prescription drug overdose deaths and more recently deaths and other complications related to use of heroin and some of the illicitly manufactured fentanyls. I think Alaska really highlights the fact that even in you get out to remote villages, there's still a challenge with opioid abuse. We had one cluster of overdoses, for instance, in a village that you can only get to after an hour-long jet ride and then several stops on a 2-engine plane. And unfortunately, that cluster of overdoses that all occurred in one day even resulted in a death. And those overdoses were related to what was thought to be heroin, but actually contained a high concentration of illicitly manufactured fentanyl.
Wow. With the remoteness, that's a completely different dynamic from what we're dealing with here in our state, the state of Ohio.
Well, I'm sometimes asked what's unique about the opioid crisis in Alaska, and there certainly are unique aspects as it is related to the remoteness of some of our areas. But I think the most impressive thing to me is the lack of uniqueness, that we're struggling with some of the same issues that people in the lower 48 as well as people throughout much of Canada are.
So in February, Alaska Governor Bill Walker declared the opioid crisis a public health disaster in Alaska. Can you tell us what led up to the governor making that decision and what the process entails?
Well, Governor Walker has had a lot of interest in the opioid crisis. During particularly his second year as governor, he was observing some of the health impact of opioid abuse in our communities and was talking with Alaskans and really became aware that it was an issue that couldn't be ignored and one that would require response. In talking with the governor and providing briefings, he was very open to making sure that he was aware of the situation and that we were engaging across the various departments of state government and working together. So at the same time that's happening, we had two drivers that really brought that disaster declaration to a head. One was our need to move ahead with a particular project we called Alaska Project HOPE. HOPE standing for Harm Reduction, Overdose Prevention, and Education. And a key part of this program was distribution of naloxone as a part of a rescue kit. And these rescue kits included the prepackaged naloxone nasal spray, some gloves, a airway barrier, as well as instructions on how to administer the drug and what to do. Most importantly, calling 911, and also if there wasn't a response, giving a second dose and commencing CPR if the responder knew how to administer CPR. Our initial plan for the Project HOPE was working with tribal organizations and law enforcement agencies, but it became apparent that we really needed a much broader outreach. And while these other organizations have the medical direction to be able to provide the prescriptive authority, we realized that we really needed a statewide standing order. And that authority didn't currently exist in statute. So the disaster declaration provided the opportunity for the governor to do that under an administrative order so that we could launch the program pending passage in the state legislature to be able to provide that authority. The other driver was the need to improve collaboration and coordination. And so we went forward with a unified command structure. And our discussions were, we had just finished a report from the Alaska Opioid Policy Task Force. We had some standing groups such as the Alaska Board on Alcohol and Drug Abuse. And so we're getting input from a lot of groups, but what we really needed to do was take action. So the governor was very open to creating an incident command structure, just as we would do if we were responding to a wildfire or a tsunami. And this brought together personnel from a number of different agencies, not only from within the Department of Health and Social Services, but other parts of state government. As we discussed it, we realized that when there's a wildfire, we don't have working groups discuss the nature of fire. We don't just get the hoses out and measure how long they are. We get personnel that are available to put the wet stuff on the red stuff and address the problem. And that there were specific steps we could be taking, things we could be doing to address the opioid crisis. So our structure within the Unified Command is any of the listeners who have been involved with incident command structure be very familiar. We have a group in charge of operations, a group in charge of planning, a group in charge of logistics, and a finances group, a joint information center, and a multi-agency and coordinating group, which is primarily the cabinet members in charge of 9 different departments that are involved in the response. And we certainly found that as we started with departments of health and social services, law, public safety, which is our state troopers, corrections, commerce, where the administration of the healthcare boards are, education, that was even more opportunity. So transportation, military and veterans affairs, and even fish and game are all part of this process now.
So let me go back for just a second. Why is the standing order so important for this? You didn't have an opportunity to issue, but now you did?
Yes. So we recognize that to get the statutory authority, it might take weeks, if not months, to be able to get that through the legislature. But ultimately, we did get a bill through shortly after the 30 days of the standing disaster declaration had expired. So the disaster declaration achieved the short-term goal of being able to launch the naloxone program and the longer-range goal of creating the structure for the interagency response.
So you did the emergency order in February, And did it just last for 30 days, the order?
The administrative order lasts longer, but the disaster declaration, any disaster declaration in the state of Alaska is defined by statute as only 30 days. And we actually have in our statute a statement that is that emergencies rarely exist and should rarely be declared. So this was really a fairly unusual measure in our state. And then as we looked at the need to renew the disaster declaration, we were close to getting the statute passed, and we recognized that we had the incident command structure up and going, so we did not request an extension of the disaster declaration. And people are quite aware that the response is continuing even as we speak today.
Okay. So in that first 30 days, what you accomplished is you got the statute passed for the standing order so that you could freely prescribe naloxone statewide, and you got your incident command structure in place with all of the people. Right.
And one of the beauties of incident command structure is it's scalable to the degree of response that's needed. And so far, it continues to actually be drawing people in. We have not found this to be a crisis that is going to just be gone in a few months. We knew that coming in, but we identify additional needs and bring additional people on board as needed. And it's important to note that this response is being done without creating new positions. Like many states, particularly those that are petroleum states, we're in a bit of a fiscal crisis. So we really had to determine the best way to scale up a full-scale response without needing a big influx of additional state resources.
So who fills those roles then?
Well, it is staff in multiple departments. We lean very heavily on the Department of Health and Social Services and the Division of Public Health. But we also have a great partnership with our Department of Military and Veterans Affairs. So we have 3 active duty National Guardsmen involved in drug prevention that are detailed to us. We have people who are in all the various departments that are doing this basically as other duties as assigned and setting aside the time to do that. And one of the advantages of a declaration and moving into the incident command structure, which does have more longevity under the administrative order, is it creates the permission within the personnel system for people to be able to commit time to this.
Can you tell us a little bit about how that works, the permission to spend time on this? These are state employees then, is that it?
Yes, the majority of people involved are state employees. We do have a few federal assignees who are working on the project as well. And I already mentioned we have even 3 National Guards personnel as well.
Okay. So other than enabling you to very quickly issue that standing order and get that statute passed, as well as get the permission for people to spend the extra hours and participate in the command structure that you now have set up, what else has declaring a state public emergency enabled you to do that you couldn't have otherwise done?
Well, I think it's probably a good time to discuss just very broadly what are the purposes of declaring any kind of state of emergency or disaster declaration, because the need to do this is going to differ from state to state, and even nationally it may depend on the circumstances. So I categorize the reasons as the 6 Ps, so personnel, pay, procedures, procurement, policy, and priority. So personnel, we've just been talking about deployment of personnel, having intra-agency reassignment or cross-agency embedding, where personnel from one agency might actually be working for a period of time within another agency. Pay, what I'm really talking about is funding. Maybe I should call it funding. But this is, it could be access to emergency funds or even appropriation of additional funds. That was not an option for us, but that's one of the issues that states need to consider as they review the possible advantages of a declaration. 3, procedures, streamlining of bureaucratic functions, and one of those would actually be the 4th P is procurement, being able to fast track and use non-traditional methods to acquire goods and services. The 5th P is policy, which certainly was one of the functions of our declaration, or one of the outcomes. And that's the need for new laws or regulations to support the longer-term response and recovery from whatever the disaster might be. And the final P is a priority. It's a statement of importance. Could be considered a rhetorical tool. I would stress that this alone probably is not a good reason to declare any kind of emergency or declaration, but it is part of how the crisis at hand gets discussed more often. One of the things that is different about the opioid crisis than other disasters is that it is much less visible. If there's a major earthquake, everyone feels it. If there's a hurricane, people see the weather change. Whereas the opioid crisis, I think the best analogy to a natural disaster is a tsunami. We suddenly realized that we were in something deep, and we didn't actually feel the seismic shift that began 20 years ago in how providers prescribe opioid pain relievers. And then subsequent waves of tsunami have come in with the influx of heroin as well as the illicitly manufactured fentanyls.
So, Doctor, you put forth a compelling argument on why a state would want to declare a state's emergency for the opioid epidemic. Why wouldn't they if they're really suffering from this terrible scourge of our nation?
Well, that's a great question, Greg. And I think the dialogue that then needs to occur is what are the needs? What do we hope to achieve through this declaration? And is there another way to achieve it? And if the answer to the question is, yeah, there's other ways we can do this, and we can do it in a way that is timely and will meet the needs of people who are suffering from addiction, as well as the needs of their families and our communities, then let's just do it. We don't need a declaration. So each state that has declared some type of emergency has had different reasons. In Arizona, there were issues related to being able to make overdose a reportable condition and to be able to detail personnel for data management purposes. So very different than the immediate need that we had in Alaska, although we have used the ongoing incident command structure to address a better way to collect and organize data in a more timely fashion.
Very good. I want to move along to other programs that you've put to work in your state to fight the opioid epidemic that you've found particularly effective that you'd like to share with our audience.
Sure. So we're only about 6 months into the incident command structure response, and because it is a complex crisis, the response also can be fairly complex. And on day one, we said this isn't really a sprint. We're running a marathon here. So I'd say we're about 10K in so far, and we still have much to do. But so far, what we've been able to achieve, I mentioned data earlier. That has been an opportunity to be more timely. I think of disaster response in terms of situational awareness, and I think many of us remember the visions of Hurricane Katrina with some government officials saying everything's under control. At the same time, we're seeing pictures of flooded streets. That was a lack of awareness and situational awareness. We have had historically fairly slow turnaround on the type of data we need to track the opioid crisis. And Data dashboards can be very useful, but if they're showing data from 2 years ago, it's very hard to gauge our response and change policy. We wouldn't drive our cars based on what the readings were 2 days ago, and similarly, we can't drive a public health program that way either.
So how did you fix that?
We are working across agencies to be able to work with preliminary data if needed. For instance, in the past, death certificate data oftentimes had to go through a review and a finalization, working with the Center for Health Statistics. We've taken that a step further in terms of being able to look at what our preliminary data reflects. And we find that the degree of error is small enough that we can live with it, that it's, we may end up adding a few cases or even subtracting a few cases when the final data is in, but it gives us a really good idea of where we stand relative to last year or the year before. The other thing that I think is really critical for the data is being able to look for clusters of events. And we have used some of the infrastructure that was created for what's called sentinel surveillance or syndromic surveillance, looking at the ER data, EMS runs. And in April and May, we saw a spike in the number of runs that were related to opioid overdose. And in checking with the state medical examiner's office, we were beginning to see an uptick in the number of deaths. We worked with law enforcement. We fast-tracked some of the toxicology testing and realized that much of what we were seeing was related to fentanyl. And so our working hypothesis, since these overdoses were all in one city, was that there was a batch of heroin that had very high concentrations of fentanyl. So we moved fairly quickly and worked with the media to get the message out that there was some heroin on the street that we had reason to believe was uniquely dangerous, and to get the message out there that using heroin is like a game of Russian roulette. But right now, there are more bullets in the chamber, and this is a great time to, if you are considering treatment and entering into recovery, it may never have been more important. Providing the guidance to EMS that if you're not getting a response to naloxone and there's a high likelihood of opioid overdose, additional doses may be needed to be able to treat fentanyl. This cluster lasted altogether about 2 weeks. Unfortunately, roughly about 10 people died, but we did not see further cases occurring outside of the city of Anchorage. And I think our measures may have helped reduce the spread of that batch out to more remote areas. Again, I can't say for sure, but we were able to get word out on the street very quickly. And particularly in a small state like ours, even a fairly small cluster or significant clustering in time could be missed if we didn't have that very proactive outreach into data.
So, Dr. Butler, what advice would you give to other states that perhaps are considering declaring the opioid epidemic a state emergency? What advice would you give to them from your experience in Alaska?
Well, I think you have to look at what are your goals? What do you want to achieve? And keep in mind that the declaration is a tool. It's not an end in itself. And if it's a tool that will help you get to where you need to be, I think it's a very rational way to go. Many people I know are sort of scratching their heads that, this is almost like if we think of addictions as chronic health conditions, this doesn't fit the usual definition of a disaster. But I think if we sort of ignore that time frame and look at the the remarkable increase in the rate of death due to opioid overdose, we can say that we're dealing with an epidemic just as we might be if it were a flu pandemic. And, that's another example of where the declaration of a public health emergency is fairly common.
Well, Doctor, I'd really like to thank you for your time today. It's the insight that you've provided us has been invaluable. So what final thoughts would you share with our listeners, Dr. Butler, about the opioid epidemic and what you've witnessed?
Well, I think, first of all, it's important to realize if you have listeners in state government, as well as everybody, as we look at the state level, there's only so much that can be done at the state level, and there's only so much that can be done by government. The real action takes place at the community level, often led by community coalitions of citizens, including medical and behavioral health providers, elected officials, local law enforcement, the faith community, family members of those struggling with addiction, and most importantly, people in recovery. This final group is really the people who give us reason for hope. For healthcare providers, I think it's important to recognize that we oftentimes don't see the successes and the people coming out on the other side of addiction and living in prolonged recovery. We generally see the failures and the complications. My clinical background is infectious diseases. So for years, I've taken care of complications of self-injection drug use, including HIV and hepatitis C. And it was those complications that I usually saw. And over the past couple of years, thanks to people in Alaska who are living in recovery, I now understand there's millions of Americans who are living in recovery. And they've been just outside of my field of view and sometimes sitting right in front of me. But because we as providers have not historically recognized addiction as a health condition that requires compassionate and science-based management, neither we nor our patients have had some of the critical conversations that need to occur. And I guess the final comment I'd make as we talk about the opioid crisis is that we also have to take a larger view that's not just molecule specific, but particularly when we start talking about primary prevention and access to treatment, that we need to recognize that there are many types of misuse of substances, and we have to take a comprehensive approach that addresses whatever the type of addiction is, whether it be opioids, benzodiazepines, cocaine, methamphetamine, or alcohol.
Well, once again, Doctor, I want to thank you.
Oh, my pleasure. Thank you, and thank you for the work you're doing.
Okay. We've been visiting today with Dr. Jay Butler, the Chief Medical Officer and Director of the Division of Public Health at the Alaska Department of Health and Human Services. Jay is also the Chairman of the Alaska Opioid Policy Task Force. My name is Greg McNeil, founder of Cover 2 Resources. Thank you for joining us for this Cover 2 PPT podcast. That's people, places, and things making a difference in the opioid epidemic.
Thank you for tuning in to this episode of the Cover 2 Resources podcast. This episode is a production of Cover 2 Resources and is made possible by listeners like you. With your support, the Cover 2 team can continue to research and broadcast these resources to others in need. If you'd like to donate or to sponsor a future podcast, please visit cover2.org. As always, thank you for listening. Together, we can make a difference in the opioid epidemic, one life at a time.